Good morning to everybody out there. How are you today? This is Dr. Soliman, another session with Your Health Today. We're going to discuss something that is very common and bothers a lot of people, which is heartburn. I feel burning sensation right here. That's a condition called GERD, gastroesophageal reflux disease. Gastroesophageal, this is exactly where the problem is. Gastro means stomach. Esophageal means the esophagus. This esophagus is basically the tube that connects your mouth to the stomach where the acid is. The stomach main function is partial digestion of food by means of something called hydrochloric acid. Hydrochloric acid is very acidic. If you put your finger there and touch the acid, you will get burned. Okay? That's how strong the acid is. Hydrochloric acid. That acid digests food, especially meat. Especially meat. Partial digestion, then the remains of the digestion will be alongside the GI tract till you get till that fat, that meat get broken down into the simplest form possible called amino acids, and it gets to your blood. So it is essential for us to have a stomach. That is the first, basically the second station. The first station for food to go through is the mouth. And the mouth, we have the saliva, which also can digest food. It has enzymes there, especially starch. We have amylase in saliva that can also digest food. So this is the second and most important station, especially when it comes to digesting proteins like chicken, fish, eggs, beef, all this kind of meat. And protein is digested mainly in the stomach. So the stomach is very important for us. So gastroesophageal meaning the connection between the esophagus, which is just a tube that transmits the food from the mouth into the stomach, and the gastro, which is the stomach. At that junction, there is a sphincter. A sphincter means like a valve. I don't know, I think Mr. Johnson can play the first image where it shows the stomach, and then we can have a little bit more detail so you can see what I'm talking about. Anyhow, that connection between the esophagus and the stomach is a sphincter. It's supposed to be tight. After food gets into the stomach, that sphincter, which is this valve, closes down. And if it closes down, that means I'm preventing the ascending of the acid or the acid fumes through the esophagus or to the esophagus. This is what I'm talking about here. So the esophagus is that higher part there where it says esophagus, and then that esophagus ends up to the stomach, and at the junction between the esophagus and the stomach, we see the sphincter, which we call LES, or lower esophageal sphincter. So if there is lower esophageal sphincter, that means it has to be an upper esophageal sphincter. The upper esophageal sphincter is not my issue today. My issue today for the presentation of patients with GERD is the LES, lower esophageal sphincter, which connects the esophagus, which is just a tube for the food to pass, to the stomach where the food is stored and the protein is being partially digested by an acid and some enzymes. But the most important thing that causes our concerns about this disease is the acid in the stomach. Which acid? Hydrochloric acid. So the pH inside the stomach is about 1 to 2. So it's about 1 most of the time, 1.5 or so. That is very acidic. That is very acidic. It can digest meat, meaning it can break meat into the simpler form or the simpler form, because there is a simplest form down below at the level of the intestine called amino acid. Then you can imagine how strong that acid is. So if this acid then happened to ascend up when there is a problem with this sphincter, the sphincter function is to close when the food get down to the stomach. That is the sphincter function. What if the sphincter failed to close? What if the sphincter failed to close? Then we have this acid, and this acid fumes that happen as a result of digestion ascending up to the esophagus. So when it ascends up to the esophagus, we will have a problem, because with this acid is very strong, so we will feel heartburn, and it's very, very disturbing, very disturbing. People who have GERD, who have gastroesophageal reflux disease, are very much disturbed. Why? Because it burns. This acid, when it gets to the esophagus, it burns, and it's very bad. Now, some people, when they get the symptoms, they go to a doctor, and the doctor tell them, okay, the next step we're going to do is to do an endoscope. We're going to insert an endoscope there. I don't agree with that. We only do endoscope. Not everybody, have a little bit of heartburn. We do an endoscope, because there is an indication to do an endoscope. And I see patients in the clinic whereby most of the times, everybody is getting an endoscope for GERD. No, we do not do endoscope unless there is two conditions. First, let's discuss when that sphincter, the LES, the lower esophageal sphincter, that sphincter that connects the esophagus with the stomach, failed to close, then we said we have a problem. This patient will have ascending gas, or from the acid, or the gas, or the acid itself, and that burns. You remember, it digests protein. It breaks down meat pieces that you eat. It breaks it down. So you can imagine, if it touches your stomach, your esophagus, you will have burn. Now, this, sphincter can be defected small, mild, or can be defected big times. That means when it's defected big times, we're going to have ascending of food that you have eaten before, ascending through the stomach, especially at night. Especially at night. So at night, the patient will cough. So when you cough only at night, and you have this heartburn, that we know what is the problem. The problem is the sphincter is too bad. That LES sphincter is too bad, that allows food that you have eaten before to ascend up, because when you sleep like this. So if you stand up, by gravity means the food is very difficult to come up because the gravity. But when you lie down, it's very much easy for the food that's in the stomach to regurge. Regurge meaning it comes back from the stomach into the esophagus, into the mouth. So when you wake up in the morning, you see a lot of food in a pillowcase next to your mouth that you have regurged through the night. So in this case, we recommend that you do endoscopy. We recommend that you do endoscopy to evaluate how far is the damage, and also at this case we can do a surgery called fundoplication, and that can resolve the problem, even though there are risks even with the fundoplication, even with the surgery, that it has complication as well. So when we do endoscopy when you see food next to your mouth in the morning, that is regurg food, volume regurg, next to you when you wake up in the morning. The second issue is when somebody has heartburn, the recommendation is something called PPI, proton pump inhibitors, like omeprazole. Everybody knows omeprazole. So omeprazole, it's a good thing to use, because omeprazole will will shut down that bomb that secrete the acid inside the stomach. So we use omeprazole. Now there are new drugs that also with omeprazole we can combine another drug that tight up the sphincter. When we tight up the sphincter small, then the gas has no chance and the acid has no chance to ascend up and cause you the heartburn. So this is heartburn. Everybody has it. We can have it in a mild form, we can have it in a moderate form, we can have it in a severe form. It all depends how bad is that esophageal gastric sphincter, the lower esophageal sphincter, how bad it is, how damaged it is. Does it close after food gets into the stomach or remains open? Now, again, to repeat, to know that you have GERD, that this is the burn in the chest. You feel burning, not stress, pressure. Burning is different. Burning, like something is burning there. That is gastro reflux disease. It happens when you eat a big meal, that especially if it's spicy, then when you fill up the stomach too much, the sphincter will have difficulty to close. You know, so when the sphincter having difficulty to close, that means it remains open small. Gas and fumes of the gas ascend up, and you feel it. So you not necessarily have a bad valve. You just overeating. You ate too much. That's why we have this. We have this scenario happening. So, but this, when the stomach size goes low, so is the the reflux goes off and it disappears, and you're feeling normal. You know, but those who have permanent defect in the sphincter, those are the ones I mean by this session here. Those are the ones that we say the sphincter could be mild, could be moderate, could be severe. Mild and all the way up to moderate, we only treat with omeprazole, lowest dose possible, and we monitor. If we having a problem still, we can add another drug called domperidone, and that will close the sphincter for me. This has to be done by a physician, not by you. I do not recommend doing endoscopy for anybody with heartburn unless we see severe destruction and damage of that LES, lower esophageal sphincter, which is the sign of which will be you see food when you wake up in the morning, and you always cough at night. You always cough at night. Only at night. You always cough, because in the daytime you're standing up. There is less chance for the acid to come up. But at night when you sleep, then we have irritation because of this acid coming through the pharynx, through the esophagus, through the larynx. So you have a little bit of hoarseness, your voice become a bit thicker, and you have nocturnal cough, which is nighttime cough all the times. And this is the indication for endoscopy at this time. Let's take 1 minute break and continue.
Facing challenges in your health? Then Dr. Soliman Clinic and Labs is here to provide you with the lasting solutions to your health problems. Dr. Soliman Clinic and Labs is specialized and offers consulting in psychiatry, internal medicine, cardiology, urology, dermatology, gynecology, infectious diseases, and infertility. At Dr. Soliman Clinic and Labs, we offer 3D/4D scan at just 5,000 francs, emergency ambulance, free ultrasound scan, and free medical consultations. Our staff is composed of well-trained doctors with good laboratory and best equipment. We are located in 2 cities, Boya at mile 18 Bolifamba, and in Douala, we are located at Entrée Pilote. You can reach us through the telephone number 694-940-172. Your health is at the right place with Dr. Soliman.
All right, welcome back. Now we're going to talk about another related issue, which is the stomach. We finished with the esophagus problem, what can happen, which is very common. Now we're going to move down a bit and we'll talk about the stomach. The thing that I want to talk to you about the stomach is the H. pylori. H. pylori is a bacteria that I think we have a picture of it. It looks like a snake, bacteria that looks like a snake, you know, like you see branch in a snake or something like that. You see it right there in the images. So if we can look at the H. pylori. H. pylori is very common. You know, it's very common in not only in Cameroon, but also, yeah, this is the H. pylori right there. You see, is that yellow thing there that look branching off. The H. pylori is an amazing bacteria. Amazing bacteria. What makes it unique is this bacteria lives inside the stomach. So you're gonna ask me, how it lives inside the stomach if you just said the stomach has a very strong acid called hydrochloric acid, and the pH, which is the strength of that acidity, is about 1.5. That is very acidic because the scale starts from 1 to 10, and I'm at 1.5. That's very acidic. And if it digests meat, why it does not digest this small bacteria there? I mean, it can destroy the bacteria. Normally, yes, if any other bacteria is being swallowed to the stomach, it gets killed. Except the H. pylori cannot get killed because this H. pylori is very smart. It protects itself by creating an alkaline medium around it, meaning it it raises the pH. Raises the pH, meaning make it more like 7, 8, you know. So it alkaline the medium. Wherever it stays, it alkaline the medium. So it protects itself from the acid by alkalinization of that medium where it stays. Basically, it removes the acid from the area where it stays, and it makes that place a bit of alkaline. So you understand? So it protects itself from the acid. You know, it lives in the acid. It lives in the acid. That's H. pylori bacteria. It lives inside the stomach. It lives inside the acid. So it's an acidic bacteria, and it cannot be killed easily. And it has a lot of symptoms that we will discuss right now. So if we have H. pylori, that is by definition a cause of gastritis or chronic gastritis if it stays for a long time, and that chronic gastritis may lead to peptic ulcer disease. So this is the H. pylori, the most common cause for making ulcers, for having you have chronic gastritis. What will be the symptoms? How do you know you have H. pylori gastritis or gastritis even without H. pylori? If you have gastritis without H. pylori, it's very easy to deal with. But if you have H. pylori gastritis, which is very common, then we have a little bit of a problem. What you're going to be looking for? You're going to be looking for belching. You always belch. Second, you're going to be looking for fullness. You're always full, even if you don't eat. You're always full. Third, and most commonly, you're going to be complaining of epigastric pain. Epigastric pain right here at the middle, right here. That's epigastric pain. Now, if this H. pylori continues with you for a long time, it can cause chronic gastritis. And from chronic gastritis, we can advance to ulcers. And from ulcers, we can advance to perforation of the ulcer, and then we have a big of a problem. So we start with H. pylori, we advance to gastritis. From gastritis, we advance to chronic gastritis. From chronic gastritis, we can advance to an ulcer. From an ulcer, we can advance to perforation. This ulcer can perforate, and then you will bleed. And that is very nasty. That is emergency. Is this the only thing the H. pylori do? No. The H. pylori is a very bad thing to have. The H. pylori is a bacteria, and is the only bacteria in the world so far that can cause cancer, stomach cancer. A bacteria causing cancer? Yes. H. pylori can cause cancer, can cause a condition called MALT, can cause a lymphoma of the stomach, and can cause also adenocarcinoma of the stomach. Both types are cancer, stomach cancer. So H. pylori is not to be taken lightly. Sometimes you will have frontal headache all the time. That is H. pylori, if it comes with the epigastric pain. So you must have the epigastric pain. You must have the belching. You must have the fullness. These are all three main signs and symptoms for someone who have H. pylori. Now there are tests for H. pylori. There is H. pylori ELISA. ELISA is a machine that gives you accurate results, but you take the sample from the blood. I don't like that. I like the more accurate way to determine whether you have H. pylori or not, and that is the stools. I look for the antigen of the H. pylori in the stools, and that is the most accurate way so far to decide whether you have H. pylori or not. So if you want to do a test about H. pylori, you ask the lab or you ask the doctor, Doc, I want to do it from the stools. I want to look for the stool antigen. That is most accurate. Sometimes you do it from the blood, even with ELISA, and it is not there. The antibodies against the H. pylori is not, it cannot be seen or detected in the blood, but yet it is in the stool. So in the stool, we're looking for a piece of the H. pylori we call antigen. We look for a piece of the H. pylori in the stool. The best, most accurate way to decide whether you have H. pylori or not is to take that piece of a stool and look for antigen. Look for the antigen of the H. pylori. Now we know we have H. pylori. So again, the symptoms start with a little bit of epigastric pain, fullness, and belching, and it then advances to chronic gastritis. And when we develop an ulcer, most likely you will feel the pain right in your back, upper back. and then you know you have a little bit of ulceration there. If you ignore it, the ulcer can go deeper and deeper and deeper into the wall of the stomach till the point that it can perforate, and now we have emergency. Okay, so now, like I said, I do not like to do endoscopy with anybody because endoscopy carries risk, and it is not recommended unless there is an indication for it. By the same means, I want to do endoscopy for this patient with gastric only if there is a little bit of bleeding. Then I need to do endoscopy to see the source of bleeding. And beside that, I will treat with medication first. So anybody who comes in with epigastric pain, if you have epigastric pain, a little bit of frontal headache, which is not necessarily in all patients. Some patients will have it, some patients who don't have it. Bulging and belching and fullness, that is the three most common signs and symptoms most of you out there complain of. And the first investigation that I need to do for you is to test for the H. pylori from the stools. Now, is H. pylori easy to treat? No, unfortunately. It's a very stubborn bacteria and very difficult to treat. We need a combination of multiple antibiotics to get rid of it. Meaning, they have what is called gastric kit. I get patients who take in the gastric kit for 7 days, and we test them. H. pylori is still there. So we have, in medicine, treating H. pylori, we have what is called sequential modality or sequential therapy, sequential protocol, whereby I treat for 10 days using 2 medication. Then I treat after this 10 days, I treat for another 10 days with more medication. So I don't hit the patient with all the antibiotics all at once. It will be a bit difficult on the patient to take. And also, so I prepare the patient in the first 10 days to accept the following 10 days with heavier antibiotics. And after this sequential therapy, 99% of the cases, H. pylori is gone. There's no more H. pylori. Now the second question will be, how did I get H. pylori? You got it from saliva. The mode of transmission for H. pylori from one patient to another patient is saliva. And how can I get contaminated by somebody's saliva? Well, number one, if you drink after this somebody from the same cup, or if you have an intimate relationship with that person and you kiss the person. Now we have transmission of the H. pylori from one patient infected with H. pylori saliva into the next patient. So if we have a husband and wife and we test the husband for H. pylori, we need to test the wife as well for the H. pylori. We also need to test the household for H. pylori. You cannot have H. pylori, even if it's a child, you must treat the child. H. pylori is not something that I want you to stay with, because H. pylori is nothing good about H. pylori except one thing. Yes, correct. There is something, well, it is not good. You have to kill it. But I need to tell you, if you have GERD and H. pylori, well, if you kill the H. pylori, the GERD, which is the heartburn, the gastroesophageal reflux disease, gets worse. Yes, because the H. pylori, like I said, produces alkalinity. It makes the pH a bit low. This is how she lives, by reducing the pH, okay? So it survives in the acid, and it even reduces the strength of the acid. So when I reduce the strength of the acid, and that is what H. pylori do, it will help me if I have GERD. So H. pylori is not all bad, but I'm just joking now. It's all bad, but it has one thing unique, especially in those patients with GERD. So if I have an H. pylori gastritis and I have GERD, gastroesophageal reflux disease, this H. pylori here will make my reflux disease better. If I get rid of the H. pylori, my reflux disease, the heartburn that I feel, will become worse. Does it mean that I leave the H. pylori? No. I cannot leave the H. pylori because it can progress to a lot of bad things. Gastritis, ulcer, perforation of the ulcer, and possible carcinoma or stomach cancer. So I'm very happy to kill H. pylori and get rid of the cancer or progression into cancer. This is how this cancer is treated, by killing the H. pylori. And we said, summarize again, H. pylori is not easy to kill. It has to go into sequential treatment, 10 days, then followed by another 10 days. That is the best way to kill H. pylori. There is no better way to kill H. pylori than this. Okay, we take another minute break and we'll continue.
Facing challenges in your health? Then Dr. Soliman Clinic and Labs is here to provide you with the lasting solutions to your health problems. Dr. Soliman Clinic and Labs is specialized and offers consulting in psychiatry, internal medicine, cardiology, urology, dermatology, gynecology, infectious diseases, and infertility. At Dr. Soliman Clinic and Labs, we offer 3D/4D scan at just 5,000 francs, emergency ambulance, free ultrasound scan, and free medical consultations. Our staff is composed of well-trained doctors with good laboratory and best equipment. We are located in 2 cities, Boya at mile 18 Bolifamba, and in Douala, we are located at Entrepilor. You can reach us through the telephone number 694-940-172. Your health is at the right place with Dr. Soliman.
Now we're going to move into something else, diarrhea. We discussed diarrhea last session, and we said if you take in antibiotics, you're most likely to get diarrhea. So if we're treating this H. pylori with a lot of antibiotics, can I get diarrhea? Yes, you can get diarrhea. And we call that antibiotics-induced diarrhea. Okay? And I told you last session, just as a reminder, you know, if we have antibiotics-induced diarrhea, the treatment is another antibiotics. Okay? So in the treatment of the H. pylori, we include that antibiotics that stops the diarrhea. The antibiotic we all know is metronidazole, because when you give antibiotic, you promote the proliferation, the growth of a bacteria called C. diff. C. diff. So when we have C. diff, C. diff induces diarrhea. So we must kill the C. diff by metronidazole. So this is antibiotics causing diarrhea, and the treatment is another antibiotic. Okay? So when you take the treatment for the H. pylori, you will not have diarrhea because the metronidazole is needed to kill the H. pylori, among other antibiotics. It's not a standalone. You cannot kill H. pylori with one antibiotic. It has to be a combination of. Now, diarrhea. You know, antibiotics is not the only way you can have diarrhea. You can have diarrhea if you have a viral diarrhea because of a virus. And this viral-induced diarrhea or a viral diarrhea is self-limited, meaning it will come, it will go. You don't have to treat for that. So now, when I have diarrhea the first day, you know, it depends. If it's watery diarrhea, I have to take measures immediately. I have to replenish the fluid, because watery diarrhea meaning you are losing volume. So we have to give you the volume that you have lost so you don't dry out, you don't get dehydrated, right? But if we have other type of diarrhea, infectious diarrhea, especially viral diarrhea, we know it's self-limited. We do not want to stop the diarrhea immediately. We want to make you flush out the microbe. So we let diarrhea go for a limited amount of time. The doctor will be able to tell you. So when we have diarrhea, we need to evacuate the microbe. So diarrhea is a good thing to evacuate, but prolongation of the diarrhea is going to get us into problems. The most important thing about diarrhea is to replenish the fluids the patient has lost. Now, doctors will know which one is viral, which one is bacterial. Just from your history, we will know. So the most bad one, the bad diarrhea, is the one that is caused by bacteria. This is the one that comes severe. It comes very severe diarrhea. That we know is a bacterial diarrhea. That one we have to treat with antibiotics. Now, it is essential that when you have abdominal distension and a lot of gases, you don't feel comfortable at the level of the abdomen, that we do something called a stool examination. full stool examination, not the kind of stool examination that have a dipstick and we look there and we tell you, okay, you have bilirubin, you have this. I'm not talking about this. I'm talking about parasitology. I'm talking about parasites looking under the microscope for what's in the stool by a professional lab technician or laboratory scientist that can determine. He knows his stuff. When he sees this egg or this cyst, he knows what microbe this one belongs to. So we need to do a stool examination. Anytime you have a problem with the abdomen, we need to see what is there. And you'll be surprised what we find when we do a stool examination. For example, we have a protozoa. It's not a virus, it's not a bacteria, it's a protozoa called Giardia. And you'll be surprised, not a lot of people have it, but during the course of my practice here in the country, we've seen quite few. Giardia, it's a protozoa that comes from contaminated water. You're taking it by mouth, and now how are you going to feel? Distended all the time, bloated all the time, and you release a lot of gases. You're not comfortable because you feel like you're distended, you're bloated, and you also release a lot of gases. If we do the stool examination, we will find this protozoa called Giardia. The treatment is very easy. 2 days and it's finished. 2 days treatment and it's finished. Then we advise to check your water source and make sure it is a clean water. Okay, so that is Giardia. What else can we find? We can find something called amoeba. Amoeba is a bad thing. A very bad thing, because it can advance to something called liver abscess. It can go to the intestine. Amoeba you take by mouth to the intestine, and it can make a hole in the intestine, leave the intestine, and go to the liver and make me a liver abscess. How do we know? Usually, any patient that comes in, we do fast-track ultrasound. And I do the ultrasound for free. My consultation as well is free. Fast-track ultrasound to look at all the organs. If something catch my attention, we know there is something here. There is a cyst in the liver. You cannot find it otherwise. How are you going to find it? You can find it only if you do ultrasound. Ultrasound is a very useful tool when it comes to diagnosing patient. Correct diagnosis. And it brings you, the patient is talking about something, and in ultrasound you found totally something else. So, amoeba, when we do stool examination, we can see it in the stools. Amoeba is bad because it causes holes in the intestine. It makes its way up to the liver and causes me a cyst in the liver. It damages the liver. And the treatment for it is very simple. There are few medication, very simple and cheap medication to get rid of it. Quite easy. So, but the whole thing is to find out that you have amoebiasis or not. So, that is the most important thing, to find out if you have amoebiasis or not. The complication of amoeba is liver abscess. You don't want to have liver abscess. And it comes also a little bit of abdominal pain, a little bit of discomfort. You're not feeling too well there. So anybody with abdominal discomfort, stool examination is the solution to find out exactly what you have. And based on what the finding, we provide the treatment, and the treatment is quite easy. It's not a problem at all. Those are small things that you have to be aware of. There are other bacteria also, like cholera, for example. Cholera, for example, and stuff like that. But we will be talking about this in another time. But anyhow, the whole idea about diarrhea is losing fluids. You must replenish the fluids. You cannot have somebody at home having diarrhea, for like a week or two. He will be dry out. Especially if you have diarrhea and vomiting, then nothing stays in his stomach, and at the same time, he's losing much fluids. We take another 1-minute break, and we'll go to our final topic.
Are you facing challenges in your health? Then Dr. Soliman Clinic and Labs is here to provide you with the lasting solutions to your health problems. Dr. Soliman Clinic and Labs is specialized and offers consulting in psychiatry, internal medicine, cardiology, urology, dermatology, gynecology, infectious diseases, and infertility. At Dr. Soliman Clinic and Labs, we offer 3D/4D scan at just 5,000 francs, emergency ambulance, free ultrasound scan, and free medical consultations. Our staff is composed of well-trained doctors with good laboratory and best equipment. We are located in 2 cities, Boya at Mile 18 Bulifamba, and in Douala, we are located at Entrepilor. You can reach us through the telephone number 694-940-172. Your health is at the right place with Dr. Soliman.
Welcome back. We're going to talk about something called malabsorption. Malabsorption is another common condition also. Malabsorption meaning you eat the food, and the whole target of the food is to convert it into the simplest form, like carbohydrates, which is starch, potatoes. You have to convert it into the simplest form, which is sugar, glucose, protein, that is fish, chicken, meat. We have to convert it into the simplest form, which is amino acids. Fat, which is the fat and the oils that you take, we have to convert it into the simplest form, which is fatty acids. So glucose, amino acids, fatty acids, in addition to the minerals, calcium, potassium, magnesium, all this has to make it from your mouth all the way to the intestine. And the border of the intestine, we call it the villi of the intestine, this is the cutoff end whereby the food goes from your mouth into the bloodstream. Because food in the intestine and remain in the intestine is not of use to me. Food in the stomach and remains in the stomach is not of use to me. So everything I eat, the whole goal, the whole target is to get it to the bloodstream. And how do I get it? Final stage of digestion is absorption through the wall of the small intestine. So it's through the wall of the small intestine that all this food that has been transformed into the simplest form make its way to the bloodstream. And this is when we can use it for different, for calories, for metabolism, for build your cells, renew all the hormones, everything. We need all those 3 main categories: sugars, glucose, there is fructose, there is other sugars as well, the simplest form of the protein, which is the amino acid, the simplest form of the fat, which is the fatty acids. We need all those to go into the bloodstream to do their work, to renew all our cells, to have all our hormones, and for us to live, to provide us with calories so we can have energy and move and do our daily function in life. What if the border where those simple guys there, the amino acids, the fatty acids, the sugars, and the minerals and vitamins cannot make it across from the intestine to the bloodstream? Then we have a problem. And this is what we call malabsorption. What happened there? In order for us to have these units transferred from inside the intestine to the bloodstream, we need to go through the villi. The villi is projection-like things that's inside the wall of the intestine, that its all function is to transport this simple form of the food into the bloodstream. What if I have a disease that eats up those villi, like celiac disease, for example? It's rare. I have not seen it. Maybe very few cases in Cameroon, but in the West it's very common. Those people in the West and some in Northern Africa also, they are very sensitive to some ingredients in the flour called gluten. This gluten, if they take bread and the gluten inside, even the smallest amount, can go and attack those villi that is responsible for absorption and wipe off the villi. And if we do endoscopy, we can see that the villi responsible for absorption has been wiped out because of a small disease called gluten disease, and that is genetically induced. Those people are very sensitive to gluten. They cannot take flour or anything that contains flour. Okay, so this is the treatment is we avoid gluten. So we find anything, before I put something in my mouth, I'm sure that it doesn't have gluten, then I will take this substance or I take this food comfortably without any problem. A second disease that is called Wibble disease. Wibble disease is actually the same thing. It wipes off the villi, but it comes with a different manifestation. Since it's a bacteria, then it has to come with fever. So we'll have a patient that has abdominal pain and rash on the skin. The skin have rash, abdominal pain and rash, and sometimes fever. And it causes weight loss because you're not absorbing. So obviously you're going to lose weight because you eat, but you cannot absorb. Now, the most important sign in this case is steatorrhea. Steatorrhea meaning the fat, when you do not digest the fat, so the fat has not been able to be absorbed into the blood. So if it's not going into the blood, it stays in the GI tract, so it makes its way into the toilet, in the stools. So when we have this stools, you will see the stools is fatty and greasy, and it floats. It doesn't sink like it's supposed to. So the stool's supposed to sink in the toilet, but when you see the stool floating, this is a problem with absorption. They have not absorbed very well. That's why we have fat in the stools. So Wibble disease is not very common, is rare. So let's now talk about another topic that is very important for us. Anyway, we do a test to determine, very simple test, to determine. We don't have to go through invasive procedure, endoscope and CT scan, and the patient ends up with millions in expenditure, but we have not gotten anything, and those procedures also have their own side effects and their own risk. We do a small test called D-xylose. It's a small thing you check by mouth, and then we scan you and we see if the test is normal, your intestine is normal. So we cancel out all those unnecessary invasive procedure to find out if your intestine is working or not. We give you a small something if the test is normal, then called D-xylose. If the test is normal, your intestine is normal. That is the end of the story. So we have to look for something else. So D-xylose is normal, the intestine is normal. We don't need to go through invasive procedure. So this is the malabsorption, and there are many types of malabsorption. We just discussed two. Let's talk about another issue that is more dangerous manifestation for malabsorption, which is that pancreas. Pancreas gives me malabsorption? Absolutely. Gives me pain here? Absolutely. And it's bad? It's very bad. Now, the thing that I wanted to tell you, there are two types of pancreatitis. We call it pancreatitis, meaning inflammation of the pancreas. If I see necrotizing pancreatitis, meaning the pancreas become deteriorating and the tissues are dead and becoming necrotic, that's deadly. If I have just interstitial pancreatitis, meaning it has not become black in color and necrotic yet, then we have a chance, very good chance. Interstitial pancreatitis doesn't kill you, but necrotizing pancreatitis, that's a killer. And they manifest with what? With the malabsorption syndrome, floating stools as well. So now we're talking about the most dangerous way when you have floating stools. This is the other end of the spectrum. The bad one is the pancreatitis, and especially if it is necrotizing pancreatitis. Now we're talking about danger zone. So having said that, pancreatitis is manifested by malabsorption as well. We have, and also the pain here, the same thing. Let's see the causes of pancreatitis. How do I know and how to prevent pancreatitis from happening? We have under the liver, we have a sac that contains bile. This sac called Gall Bladder. We have an image of it. If Mr. Johnson, please play it, I appreciate it. So the audience can see what is the Gall Bladder and what is the condition I'm talking about. So this small sac there under the liver called Gall Bladder. And it has, yes, this one here. You see the green one, the green organ there, the sac I'm talking about. And that is what is called Gall Bladder. Inside the gallbladder, you see some stones there, and that's what we call gallstones. From the gallbladder there, where the stones are, there is pipes that connect the gallbladder to that part of the intestine they're called duodenum, second part of duodenum. This is part of the intestine. And is joined, as you see, by another pipe coming from the pancreas. And when they all join, now they go to the duodenum, and that is what is called common bile duct. Common because it joined two ducts. One is the one that is coming from the gallbladder, and the second one that is coming from the pancreas. Now we have common bile duct. Common bile duct is a place that if we do have stones, there is a possibility of those stones to move from the sac, the gallbladder, make its way in the common bile duct, and then we have a problem. We have a big problem. Why? Because once the stone launched right there, as you see it in the image, once the stone launched right there, the bile is not capable to make it through to the duodenum. Then you're going to ask me, what is the function of that bile? Why is it like this? Why we need bile? We need bile to digest fat. So bile can digest fat. That means if you put bile with a piece of fat, it will be dissolved. So if we have this stone blocking the way for the bile to enter the duodenum, because the duodenum is part of the intestine. You take the piece of meat or piece of fat from your mouth, it will make it through the intestine, then you need this bile to help digest the fat. In addition to the enzymes, yes, this is another ultrasound image. We're going to talk about that in a moment. That is cholecystitis. We'll talk about this in a minute. So we need this enzymes, we need this bile to digest our fat. When we get a stone in that pipe there, connecting the gallbladder to the duodenum, if we get a stone there and we get complete blockage, then what happened to the bile? The bile will not be able to pass. So as a result, what happened to the storage in that sac? The sac will get dilated. So for me, when I do fast track ultrasound and I put my machine, any patient that comes in, I take the history, next step, take your clothes off and lie down, let me do a fast track ultrasound. If I saw, and I found a lot of cases by accident, he didn't even know. So when I do this and I do the ultrasound and I see the gallbladder dilated, I know there is a problem in the common bile duct. Then there is a small couple of tricks with ultrasound, and I will see signs that tells me there is definitely a stone in the common bile duct. And we said the common bile duct is the connection between the gallbladder and the second part of the duodenum. Now, and you see also there was another tube, another connection coming from the pancreas into the duodenum, and they join together in a small pipe there. So what happened if that stone get block the tube? Then we have, like I told you, dilation of the gallbladder. It keeps on dilating, and the bile coming from the liver getting stored there, but is not being released. So this balloon gets getting bigger and bigger and bigger. When the balloon gets bigger and bigger and bigger, there is a chance for infiltration. That means that bile can infiltrate, can go through the now thin membrane, because we're ballooning out, it becomes very thin. So we can have this bile going through that membrane into the nearby organs, especially what is there nearby is the pancreas. So when that bile gets to the pancreas, we have inflammation of the pancreas, and that is what we call pancreatitis, and that is what we need to pay very close attention to. Now, when we have pancreatitis and the situation has not been correctly evaluated, then pancreatitis will continue over the time, a year or two, to continue to become chronic pancreatitis. And then the next time I do an ultrasound, I will see the dilated, if the patient ignored it for too long, I will see the dilated bladder, if it has not, if he still lives, and then I will see chronic pancreatitis, and an ultrasound it will be manifested by calcification, hyperechoic lesion at the level of the pancreatitis. I think we came to the end of our session today, but we have not finished chronic pancreatitis and the risk that can be considered against the patient health with chronic pancreatitis, how to avoid chronic pancreatitis, how to recognize chronic pancreatitis or acute pancreatitis is very essential, and comes all from the gallstones. Gallstones are easily explored and seen by ultrasound. So if we have gallstones, we need to pay attention. What are the chances one of those stones makes it across the pipe and block the pipe and cause me all these bad things? In the next session, next Saturday, we will discuss more about gallbladder stones, how it causes you pancreatitis, and what else can cause you pancreatitis, and how to prevent you from having pancreatitis by a very simple visit to the doctor and a very simple ultrasound exam if you do have the symptoms. If you do have the symptom. If you don't have it, you don't have it. What is the most common symptom when I have a stone? Right upper quadrant, in the right side, right upper quadrant. If you push here with your finger even like this, you will feel a lot of pain. You will feel a lot of pain. We have not finished what I need to talk about this session, but inshallah next Saturday we'll talk about it. We'll talk about the gallbladder disease. We'll talk about the gallbladder stones. We'll talk about the most deadly disease, which is acute pancreatitis, especially if it's necrotic pancreatitis. Thank you very much, and you do enjoy the weekend, and I'll see you next Saturday, 9 o'clock in the morning. Thank you.